So greetings, I'm Julie Taguchi. I'm one of the medical oncologists in the community of Santa Barbara now. And I want to thank the Breast Cancer Resource Center for inviting me to give this lecture on sexuality and intimacy. In 2005, I actually developed a lecture called Sex and the Survivor because it was really evident to me while I was taking care of women with breast cancer that their sexuality and function suffered along with the treatments. And so I was doing some research and I realized there was actually very little research involved. So just so you know, in 1999, what was available was that people just didn't talk about sexuality. There was a study in 500 women that were surveyed, and the majority of 70% felt that there was that the doctor would dismiss their symptoms, that there would be nothing to help them. And they also were concerned that maybe the doctor would be uncomfortable having the discussion with the patient. And so patients expected very little from their physicians. And in 2017, a paper that I looked at, the Japanese medical schools only allowed 90 minutes of sexuality in their medical care. And now it's really interesting because now people want to know more because of the transgender population that's becoming more common. Well, in 2019, and I would even assume 2021, patients are still reluctant to bring up their sexual concerns with doctors. And there's several reasons. One is they don't really know who to talk about, who to talk to. Do they talk to their gynecologist? Do they talk to their, primary? So that's one problem. And some people don't even think of sexual health as a medical issue. There's still social stigmas around the conversation of sexuality, particularly if they think that sex is for pleasure instead of reproduction, so they're just concerned. There's an assumption that older women don't engage in sexual activity or are not interested. And there are several people who are still embarrassed to talk about about sexuality in general. And that's all ages, races, education levels, and relationship status. And there are women, or men, I should say there's women who are concerned that their primary care lacks the sensitivity and mostly the time to discuss these issues. And then some people don't think there's any treatment for their problem, and it's natural not to be sexual or it's natural to have these problems. So again, patients are still reluctant to bring up these topics, and a lot of them cited reasons like negative body image, the lack of self-confidence, and some cultural differences in the attitudes towards sex. Now this, is data that I presented for just women in general, okay, in a gynecology office or a family practice office. So we're in a sexuality and intimacy discussion and lecture today, so we're going to define sexuality as a person's capacity for sexual feeling. So it's a feeling, okay? And since we're talking about sexual function and sexuality, we're going to review the female sexual cycle. And so we're going to start at the right lower corner where it says sexual stimuli. Now it's really important because this is where it's going to start. And if you notice, it says psychological and biological factors govern the ability to become aroused and stimulated. And that's really important for women. Women have to feel safe, they have to be relaxed, and they can't be stressed. So this something has to be allowed for this to happen. And then once there's arousal happens, there's a change in the tissue, there's vaginal moisture, then there's the sexual desire. Now there's a little box up there that says emotional and physical satisfaction, and really is a code word for climax. Once that happens, there's a whole release of a set of hormones that are released, particularly oxytocin, which allows that warm, fuzzy feeling of closeness and emotional intimacy. And once you have the emotional intimacy, then it kind of imprints or it continues or allows the cycle to continue, right? Be safe and cozy and close. And truly, that is a mind-body connection, really, right? The mind-body has to be in sync for a sexual activity. Now, believe it or not, there's something called female sexual dysfunction, and it's in the diagnosis It's diagnosed in the psychiatric, the DSM-5, I guess it's DSM-5 something now, but anyway, it's in the psych literature. And so they define the sexual disorders as the inability to have desire, like lack of desire, lack of arousal, inability to have an orgasm, painful sex, and something called vaginismus, which is just a spasm of the vaginal entrance. So these are actual definitions in the medical literature. And the thing about, I'll go back to the thing about this particular, these fields is that they're common. It's 40% worldwide, 40% of women worldwide have some form of sexual dysfunction. And in the United States, the data shows somewhere between 23 and 63% of women having some of these problems. Alcohol, smoking contribute to this, stress, financial burden, aging, lots of reasons for it. And then finally, in terms of aging, as time goes on, women lose their estrogen. And estrogen is very important for sexual function in addition to reproduction. So this is just a little chart to show you that estrogen has like over 4,000 important functions, but it certainly targets and helps the brain think. It helps the cardiovascular system, helps with your bones and your joints. And I could go on and on and on, skin, etc. So even intestines and immune system. So it has a significant influence. So I gave you some information that sexual dysfunction is common among women worldwide. But if you add a breast cancer diagnosis to that, we're talking about this particular population, these women who have breast cancer will have some sort of physical change with surgery, most likely. And so there's a change in body image. They may be offered chemotherapy or may have chemotherapy and it may induce menopause or likely to induce menopause for a premenopausal woman. And the period or menses may be restored or may not. And then radiation is a possibility, and radiation certainly causes changes to the breast and tissue. And if the tumor is estrogen receptor positive, then anti-estrogen therapy, or they call it endocrine therapy, will be offered for at least 5 years. Now, there is a significant amount of sexual dysfunction in women with breast cancer. There's a lack of desire, or lack of vaginal moisture, the inability to climax, and dyspareunia. Everything we just talked about is more prevalent in this population. It's been reported up to as high as 90%, and consistently in multiple reports of over 60%. There are several challenges, right? We just talked about a few of them. So we talk about a body image change. There's physical alterations, right? If you're in chemotherapy, you may lose your hair and be bald. You may be missing nipples. You may be missing, part of your breast, the whole breast, or both breasts, right? There might be presence of scars. I had a patient who really, the only thing that you could see was a teeny little scar on the upper part of her breast, and it showed right where maybe her shirt was open. And it bothered her to no end because she felt that it was an announcement to the world that she had had breast cancer. And so that really bothered her. People get concerned about how they appear in their clothing. There's changes in the skin itself, particularly if there's radiation problems. Women who have breast implants, they feel like, okay, they feel like there's things on their chest that these implants don't really feel like they're part of their whole body. At least that's what I'm being told. But these are things that the person has to work with, and that impacts the body image, right? There's emotional challenges as well, right? When somebody has breast cancer, there could be the whole flood of, anger. Why did their body betray them? Or they felt guilty because maybe they didn't get their mammogram last year and they missed a year, but they carry those kinds of thoughts. There's also lots of fear, the fear of dying right off the bat. I mean, people are really concerned. This is a big issue for them. And they're concerned maybe about not being attractive, they're not having functioning body parts. And of course, for the younger population, there's a concern for the loss of fertility. So other challenges that women with breast cancer have is the loss of estrogen. So a premenopausal woman who gets chemotherapy will be slammed immediately into menopause, or most likely, I would say. Sometimes women who are on tamoxifen, they may have their periods, but they're still feeling the symptoms of low estrogen, as we'll talk about further. Women who are postmenopausal on hormone replacement, they're instructed to stop their hormones, and so these hormones are stopped cold turkey, and they have symptoms from this. So it's the loss of estrogen in both these populations, and even the loss of testosterone for particularly the younger population. There are also other challenges like within relationships, because breast cancer affects the entire family. Okay, it's not just the patient herself. So there's role reversals. Could be unmet expectations, where when somebody's going through this new diagnosis or ongoing treatment problem of having to deal with, oh yeah, I'm still married, so I have to be sexually active, and I'd rather watch the rain fall or something else. So there's a lot of stress in that regard. And of course, the same issues of fear. What if something happens? Or what if I can't be myself? There's guilt because I can't maybe perform or help their spouse in their physical manner, and concerned about control. And because certainly when somebody's going through cancer, somebody wants to take care of somebody, or maybe there's just a lot of different things that happen within that relationship. And so these relationships change with these diagnoses, and body changes. So a good question to ask is, why is estrogen blocked or deprived for estrogen receptor positive breast cancer? And really it's because some percentage, not all of it, or not all women with tumor with it, but women who have a estrogen receptor positive breast cancer may have some micromets or some tumor cells that might be hidden, you can't see them, or they're resting, and that suppression of estrogen for some of these tumors, because not all of them are estrogen, believe it or not all of them are estrogen sensitive. So suppressing estrogen at the time of diagnosis will prevent the further growth of this population. And this then will translate into a survival benefit for that particular woman. So we actually recommend estrogen suppression for all women with estrogen receptor positive breast cancer, because we're not quite sure who will benefit. We want everybody who can benefit to benefit. And if you're on these estrogen blockers, it reduces the risk of cancer in the contralateral or other breast. So now we're going to talk about the different types of endocrine therapy for breast cancer. And what they do is they basically block or stop estrogen. And they're categorized as SERMs and SERDs, aromatase inhibitors, and GnRH inhibitors. So the SERMs, these are serum estrogen receptor modulators, and the most famous one is tamoxifen. And tamoxifen is a prodrug, and it actually needs the liver to metabolize it into the active form. And once that happens, then the drug then will bind to the estrogen receptor, blocking, it binds it so tightly it does not allow the circulating estrogen in the system to work. And that's why we can give it to premenopausal women. And believe it or not, if you're on tamoxifen, you can actually take estrogen because you can't really affect the body because it's being blocked by this particular drug. SERDs, serum estrogen receptor degraders, and the most common one we know as Faslodex or fulvestrant, and that's an injectable muscular preparation, and there are pills that are going to be coming out soon. But this particular agent, it binds to the estrogen receptor, and it actually degrades it and folds it into the cell. So it basically dissolves it, and so there's no receptor there to even act upon by estrogen. Aromatase inhibitors are actually indicated for postmenopausal women or premenopausal women who have the GnRH inhibitors. So it stops the function of the ovary, and then they can give the aromatase inhibitors to stop the function of the androgens from the adrenal gland that get converted into estrogen. The common aromatase inhibitors are anastrozole or Arimidex, letrozole or Femara, and aromasin. And the way they work is that in a postmenopausal woman, there's actually estrogen being made. It's made from the adrenal gland. In this little diagram here on the right, it's on which these glands sit on top of the kidneys. And as you notice, cholesterol is the backbone for all these hormones. And DHEA is made in the DHEA is made in the adrenal gland. and it gets converted to androstenedione, which then aromatizes to estrone in the fat. Estrone is a type of estrogen. And if this occurred in the ovary, there would be testosterone, which is aromatized to estradiol. So the aromatase inhibitors basically stop the function of the aromatase from converting the androgens into estrogens. And I think it's important to understand that when that happens, this is like a castration for women. So this is what's happening. And so all the symptoms that go along with these medications are a result of that particular consequence. So gonadotropin releasing hormone inhibitors are usually injections. They basically stop the brain from giving the signal to the ovaries to ultimately make estradiol in a premenopausal woman. And estradiol is needed for ovulation. So these medications stop it. And this is the same medication used for prostate cancer to reduce the testosterone production in men. We're going to talk about intimacy now, since it's a sexuality and intimacy discussion. We're going to use intimacy and define it as mutual vulnerability, openness, and sharing. And when you should know, and I'm sure it's understandable, that when a woman has these issues with a breast cancer diagnosis, it may be hard to feel this way or hard to feel intimate. So we're going to figure out what to do at the end. So in terms of management, there are definitely things that you can do. Exercise is really important for someone going through their breast cancer diagnosis. In addition to keeping somebody strong, right? It elevates your stamina and it elevates your mood. Relaxation is important because it's a stress reducer. Getting enough sleep or sleeping well is really important because that obviously keeps you rested, and that's when your immune system works and is regenerated is during sleep. It's important to be well hydrated and to have a nutritionist diet. And when it comes to sexuality and intimacy, it's really important to be patient and take time for arousal. Now, how does that happen? We'll figure that out. And what I really want to talk about is that vaginal estrogen, or DHEA, which is an androgen, they're both hormones, can be used in the breast cancer population. Now, all estrogen preparations have this black box warning. And it happened since the Women's Health Initiative in 2002, I believe, or 2003. And it says that estrogen can cause cancer. And there's a lot of things that have happened since then and have changed over time. And that's the big fear, and that's why doctors have been reluctant to give women estrogen. But multiple studies show that vaginal estrogen does not cause breast cancer. There's no association at all whatsoever. And the breast cancer thought leaders, they agree that vaginal hormones are acceptable for basically all categories of breast cancer. That's estrogen receptor negative breast cancer and estrogen receptor positive breast cancer. But they recommend the lowest dose of estradiol, possible. So what are the treatments for vaginal health? So we have vaginal hormones, and they come in different preparations. There's vaginal creams, there's suppositories, and tablets and capsules. There's different types of hormones too. There's estradiol, there's the conjugated estrogens, there's DHEA, which is the androgen, which I talked about before. There's a brand name called, I think it's Derosa. Estriol is a compounded type of estrogen. It's weak, and it only binds to the estrogen beta receptor, which is in the vaginal tissue and bladder tissue. And you can also combine these estradiol or estriol and testosterone even as a compounded product. There are different non-hormonal treatments. These are over the counter, and they have all kinds of different, mostly organic, right, depending on who you're looking at, ingredients. So coconut oil, and there's a whole list here that you can read. And there's a few of them. There are even drugs that address this issue that's FDA approved. It's called ospemifene. And it is a SERM. It's exactly like tamoxifen. So it has the same side effects of tamoxifen. So it will block the estrogen receptor in some places, but it does allow the vaginal tissue to be supple, so that's why they can give it. There is something called vaginal rejuvenation, and it's a laser therapy to the vaginal tissue. It's expensive, and it doesn't last, and so you have to go in for repeated therapies. We're moving on to another type of sexual dysfunction called hyposexual desire disorder, and there are medications to address this as well. I'm going to leave them here. I have never prescribed them for my patients, so I'm not familiar with how people respond to them. But they are FDA approved, and they're available. And of course, there's the usual treatments or exploration of things like music, lubricants, toys, and other herbal products that are over the counter that you can find and buy and explore. And we talked about intimacy. We talked about it's the mutual vulnerability, mutual openness and sharing. And it's obvious that communication is the key to that. And communication is the key to intimacy, right? What is it that you need to feel safe, to be open, to be obviously vulnerable, relaxed, and what makes you feel alive? You know, what needs do you have that can be shared and communicated to your partner? Okay, those are really that's really important. So you might need, 2 hours of foreplay. It's okay if that's what you need. I mean, you should be able to communicate that. And the question of the day, right? What is the largest sexual organ? Ta-da! It's the brain. The brain is the largest sexual organ. Now think about it. And I mean think about it. The mind can recreate a scene, or you can recreate a scene in your brain that was exciting and wonderful and great. When you think about that, your brain will send those same signals of feeling wonderful to the rest of your body, and your body will respond. Now, this is that mind-body connection I was talking to you about before. It's real, and it can happen even if you don't have hormones. Okay, it may take longer, but it's there. And we're so fortunate to have it. Everything is stored here, and you can do that. Whatever stimulates your brain can do that. In summary, we're going to say that sexuality is a feeling. Emotions and hormones drive our libido, right? Women need to feel safe, playful, and flirtatious. And it's true, estrogen definitely helps. It helps reverse vaginal dryness, it makes the tissue supple. We know that fear and anxiety dampen libido, and a lot of women with the breast cancer diagnosis have a lot of that. So understanding all this, I hope will make you understand and make you feel more comfortable. But really, in the end, it's intimacy, it's communication, and most importantly, you need to take the time for yourself, be slow, and enjoy. So I want to thank the Breast Cancer Resource Center for this opportunity for me to give this lecture and this talk to you all. And again, I'm Julie Taguchi, and community oncologist, and I'm happy to answer any questions if you need them. Thank you so much.